Now, what we found is that epigenetics is actually heritable and it's actually reversible. And we can now manipulate these principles with pharmacotherapy, drugs.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Zack, Clinical Assistant Professor at the Marcella Niehoff School of Nursing at Loyola University, Chicago, and RN3 on the Inpatient Malignant Hematology Unit at Rush University Medical Center in Chicago, about the epigenetic drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Eric.
Thank you for having me.
All right, so to start off, can you give us a brief overview of what the epigenetic drug class is and what's the history of it in the field of oncology?
Let me preface this that I'm an oncology nurse, so I'm not a physician or cell biologist or pharmacist for that matter. But back in 1942, Conrad Waddington was an embryologist who first described the difference between genotype and phenotype. And we know from studying cancer that the process of initiation and promotion occurs by both genetic and now epigenetic events. And again, we've always known that cancer is genetic, meaning that it affects DNA and genes and the behavior of the cells. And we typically know that majority of cancers are sporadic or acquired over one's lifetime. Now, about 5 to 10% of cancers are hereditary, where you inherit the risk from your parents' germline. But we do know that it all comes down to substances that are in the environment that initiate some of these changes in the DNA sequence, which then codes for genes, which then codes for proteins and enzymes that control cell behavior. And we can understand how cancers can begin with that process. But epigenetics is actually how the DNA is chemically modified to control gene expression without changing the DNA sequence, meaning without changing that order of nucleotides. Because again, there's a reading frame to that. Now, what we found is that epigenetics is actually heritable and it's actually reversible. And we can now manipulate these principles with pharmacotherapy, drugs. All of our cells have the same DNA, and some genes are turned on, some genes are turned off. That's why your brain cells function like brain cells, your skin cells like skin cells, etc. But cancer cells do the same thing. And we know that only about 1% of our DNA codes for genes, which means about 99% does not. And it's these proto-oncogenes and the tumor suppressor genes that are key for managing the cell cycle. And again, when you have a mutated proto-oncogene, it converts to an oncogene. It essentially is a gas pedal for that cancer. And tumor suppressor genes actually protect us from cancer by slowing down or preventing cell division through cell cycle checkpoints in the gaps between synthesis and mitosis. Now, when we talk about wild type is the normal, healthy gene that we see in the population. When we talk about a variant is actually a mutation in that gene that could possibly cause something like cancer. Now, we first seen evidence of this back in 1960 with the discovery of the BCR-ABL1 fusion oncogene, which is basically a chromosomal translocation of chromosomes 9 and 22. One breaks off, the other breaks off, they connect and make an oncogene. And again, it's kind of known as the Philadelphia chromosome. Now, during that time, prior to that, pharmaceuticals were investing in low molecular weight molecules, basically small molecule technology. And these drugs can actually go into cells and block signal transduction to the nucleus and therefore manipulate the cell's behavior. We call these drugs TKIs, tyrosine kinase inhibitors. And they're basically have the suffix of NIB, NIB, which stands for inhibit, small molecule inhibitors of kinase enzymes. And our first drug, FDA approved for this epigenetic process, came in the form of imatinib in 2001. And then in 2006, dasatinib, first generation and second generation drugs to kind of block the Philadelphia chromosome. So the DNA mutation is there and it will always be there in those cancer cells, but now they had drug therapy that could block the gene and essentially stop that process. allow the cells to differentiate and allow those cancer cells to go into apoptosis or programmed cell death. And again, these two drugs were approved for CML and ALL. Now, we know from experience that cost is an issue and adherence. These cells and the daughter cells that derive from them have what's called an oncogene addiction. The DNA mutation is there, that translocation is always there, that gene is always there, and then the drug silences the gene. As long as the patient's adherent with the drugs, it usually works. Over time, though, if it's a cost issue, if it's a side effect issue, whatever the issue is, and they stop taking their drug, the gene turns back on, and then it becomes more resistant. So the current drugs don't work. Then we have progression, usually to a blastic phase of that disease, which is more serious. The second great example is back in 1990, we also found the PML-RARA gene, promyelocytic leukemia retinoic acid receptor alpha. And again, another chromosomal translocation between chromosomes 15 and 17, break off, reconnect, make an oncogene, and this causes APL, also known as M3 or subtype of that acute leukemia. Tretinoin was a drug that was FDA approved by the United States in 2004, basically took those undifferentiated cancer cells of APL and converted them to normal myelocytes, which would then possibly go back and hurt the lung. But we'll talk about that differentiation syndrome. And again, the example I use there is a faucet and a sink. So with APL, with that translocation, the sink is pouring water. The bone marrow is the analogy of this faucet, pouring water into the sink. The water is overflowing. That's the cancer cells floating into the circulatory system. And again, tretinoin converts those overflowing water, those cancer undifferentiated cells, into differentiated cancers or normal cells, whereas we still have to use traditional therapy, idarubicin, daunorubicin, arsenic, to shut off the sink.
That's great. Thanks, Eric, for that very comprehensive review. I just remember hearing about when imatinib first came kind of on the scene and just how revolutionary that truly was for CML. So thank you for kind of explaining the history and the background of that and how these epigenetic drugs have evolved kind of over the recent history. Can you talk us through some of the primary subclasses of epigenetic drugs and in general, what their mechanism of action is?
Let me take one step back. Epigenetics is influenced by several factors. Right now, there's about 7 of them that we've identified, and we can only manipulate right now about 2 of those 7. So the first one is DNA methylation. When you methylate DNA, that's adding or subtracting a methyl group, which is CH3 chemically. The addition of methyl to DNA tightens the DNA around the chromatin, which then can block some genes from being expressed. When you do the opposite, you hypomethylate the DNA, you actually loosen the DNA around the coil, and that allows transcription factors to read that frame properly and express that gene. And we found that a lot of cancer cells hypermethylate that DNA. So we developed drug therapies to do the opposite. The second thing that affects epigenetics is histone acetylation. This is, again, adding or subtracting an acetyl group from the histones. Acetyl group is CH3CO chemically. Histones basically package DNA into the chromatin, which is a mixture of DNA and proteins, and they spool around this structure like the DNA is coiled around that. And again, it has to do with how tight or loose that is coiled. That determines if the genes are expressed or not. And again, we found that histones also play a role in DNA repair as well as regulating the cell cycle. Now, when you deacetylate, when you take away acetyl groups from these histones, you tighten the DNA and block expression. When you add acetyl groups to the histones, you loosen the coil, loosen the DNA, and allow that transcription, the gene, to be expressed properly. Cancer cells deacetylate, they take away the acetyl group, and our drug therapy is to increase that acetylation. Now, the other ones that we have not had success with is phosphorylation, deamination, ubiquitization, simulation, and ADP ribosylation. We have not had success with that yet, but we do have success with the first 2. So of the epigenetic drugs that we have available, besides, again, imatinib and dasatinib, as I mentioned earlier, we have these DNA hypomethylating agents. These drugs, basically, azacitidine was FDA approved in 2004, and decitabine was approved in 2006 for AML or high-risk MDS. And these are basically hypomethylating agents as well as considered antimetabolites. Essentially, azacitidine and decitabine are pyrimidine nucleoside analogs. They're basically counterfeit bases. They look like cytidine. They insert themselves into that cancer cell's DNA. And then what they do is they block the gene. And that gene codes for methyltransferase. Methyltransferase is the enzyme that adds methyl groups to the DNA. So with hypomethylating agents, azacitidine and decitabine, we can hypomethylate that, loosen the DNA, and express tumor suppressor genes that are already there. Tumor suppressor genes slow down cell differentiation and block cell progression, again, through these checkpoints. So again, very protective nature. The second drug class are the HDAC inhibitors. HDAC stands for histone deacetylase inhibitors or blockers. Now, again, same kind of philosophy here. The cancer cells promote deacetylase enzymes, which means they take away acetyl groups, tighten the DNA around the chromatin, and block expression of tumor suppressor genes. And therefore, the cancer then goes forward. So the HDAC inhibitors, there's 4 drugs in this class, essentially increase acetylation by blocking that enzyme and therefore loosens the DNA, expresses the tumor suppressor genes. So the 4 drugs are varinostat, FDA approved in 2006, romidepsin, approved in 2009, belinostat, approved in 2014, and finally panobinostat in 2015. Now, varinostat, romidepsin, and belinostat are approved for cutaneous T-cell lymphoma, whereas panobinostat is approved for refractory myeloma. Now, again, we've talked about the NIBs with the previous drugs, but 3 of these 4 drugs end in stat. That's a suffix that they use for stat, varinostat, panobinostat, belinostat. Stat stands for signal, transducer, and activation of transcription. And transcription is simply just the process of copying the DNA sequence into the RNA into the proteins. And we know that these stat enzymes have a lot of function with cell growth, differentiation, and apoptosis, as well as an interaction with the immune system. Now, the third drug class that we have for these epigenetic drugs are called the IDH inhibitors. IDH stands for isocitrate dehydrogenase. And again, this is, there's 2 subtypes, IDH1 and IDH2. IDH1 is the gene that produces an enzyme that helps break down fats and protect cells. It's found in the cytoplasm of that cell. And again, the wild type is the normal type. IDH2 is typically found in the mitochondria, and this has to do with producing energy for that cell. Again, the wild type is normal type. But when you have mutations in the IDH genes, whether it's a mutated IDH1 or 2, it leads to an oncometabolite called 2-HG, or 2-hydroxyglutarate. This oncometabolite from the mutated versions of the IDH enzymes leads to cell proliferation, uncontrolled growth, blocking immune cells to get to the tumor, what we call a cold tumor effect, as well as a whole slew of other issues. And now we have 4 drugs in the IDH inhibitor class. So back in 2018, ivosidenib was approved. 2022, olatosidenib. And then we have an IDH2 inhibitor, enasidenib, which was FDA approved in 2017. And then finally, we have a combined IDH1 and IDH2 inhibitor called vorasidenib, which was approved in 2024. Now, the IDH1 and IDH2 individually are approved for AML, MDS, and cholangiocarcinomas, which is basically cancer of the bile duct, whereas the vorasidenib was approved for astrocytomas and oligodendrogliomas, which are brain tumors. These IDH inhibitors also use that suffix nib because these, again, are small molecule inhibitors of those kinase enzymes. And our 4th and final new drug class in the epigenetic model are these EZH2 inhibitors. EZH2 stands for enhancer of Zist homolog 2. And basically, this is mostly in the nucleus of that cell. Wild type is normal. Variant is a mutation. And again, using methylation again in the histones, adding a methyl group, tightening the DNA, blocking expression of a tumor suppressor gene that's already there is usually the pathophysiology. And so we have EZH2 inhibitors. There's a new first-in-class drug called tazemetostat, FDA approved in 2020 for this, which basically hypomethylates that histone, again, re-expressing the tumor suppressor genes that are already there and then blocking the cancer process. And again, this tazemetostat was approved for epithelioid sarcoma and relapsed or refractory follicular lymphoma.
Outstanding. Well, certainly this is not entry-level stuff that we're talking about. And so I really appreciate, especially how you describe and sort of give that picture for us to imagine as we talk about these very complex concepts that we likely weren't even taught when we first learned about the cell. And if we were, we all probably forgot about it. So thank you for reminding us and kind of giving those visual descriptors for us to imagine how these drugs function. It's very helpful. So what are some of the common toxicities or adverse events that are associated with these different classes of epigenetic drugs? Do they share any common toxicities, or are they unique to the individual agent?
There are some uniqueness, but you're right, there are patterns. So let's start with the DNA hypomethylating agents. When we're dealing with the azacitidine and decitabine, these drugs cause pancytopenia. Pancytopenia is neutropenia, thrombocytopenia, and anemia. So it affects the complete blood count. We see GI toxicity, nausea, vomiting, diarrhea, constipation sometimes, mouth sores, and urticaria, hives. With the HDAC inhibitors, we have our vorinostat, romidepsin, panobinostat, and belinostat. These we see similar patterns, pancytopenia and primarily thrombocytopenia, so increased risk of bleeding. We also see some really significant GI toxicities with nausea, vomiting, and diarrhea, loss of appetite, and fatigue is a big problem with the HDAC inhibitors, tiredness. We also see cardiac toxicity, which is new. This is an evidence of prolonged QT intervals. And again, the QT interval is basically ventricular depolarization and repolarization, a really important length of time when we do that EKG reading. And when it's prolonged, that does set the patient up for potentially fatal dysrhythmias. And again, there's several drugs that prolong the QT interval, and you need to be aware of those. And again, we use our pharmacy colleagues to help identify those because, again, there's an additive toxicity when we combine the HDAC inhibitors with other drugs that are known to prolong the QT interval. And again, electrolyte abnormalities, specifically potassium, that could also potentiate or precipitate some of those prolonged QT intervals. The IDH1 and 2 inhibitors, ivosidenib, olutasidenib, vorasidenib, and enasidenib, also have some GI toxicity, nausea, vomiting, diarrhea, fatigue, again, elevated liver enzymes. Again, we do see thrombocytopenia and other pancytopenias. We do see the prolonged QT interval as well with this class of drugs. And unique to IDH inhibitors is this differentiation syndrome, which again, we saw that with tretinoin converting immature, undifferentiated cancer cells into mature cells. And there's a consequence to that when the tumor burden is quite large. IDH inhibitors do the same thing. And again, the issue here is, again, you have cancer cells turning into normal cells, but then releasing cytokines, those chemical messengers that talk to the immune system and bring a lot of inflammation into the lung specifically, cause some really bad pulmonary toxicity, dyspnea, hypoxia, pulmonary infiltrates, pleural effusions, and the patients can have some real difficulties with that. And then finally, with the EZH2 inhibitors, again, we see fatigue, we see anemia, nausea, vomiting, diarrhea, aches, elevated triglyceride levels, and uniquely a risk of secondary malignancies, which is in the form of MDS and AML.
Wonderful. Thank you for describing all of those. Again, it's always unique to consider how similar classes have similar side effects, but how they can still be unique depending on their exact mechanism of action. So you did a great job of helping to explain both how they're similar, but also how they differ. So let's move on and talk about some of the pharmacologic strategies that we can use to either prevent or help to manage these toxicities. And also if there are any non-pharmacologic strategies, if you could elaborate on those as well.
Physicians and advanced practice nurses typically grade these toxicities when they're assessing their patients, and we use standardized tools like the CTCAE, Common Terminology Criteria for Adverse Events. And again, as a bedside nurse, you're also assessing your patients for these possible side effects and then documenting that and communicating it and escalating those concerns to the healthcare providers. Oftentimes we see a lot of prophylactic meds used, again, because of the risk of pancytopenia that's across the board. So they may put them on prophylactic antibiotics, prophylactic antivirals, prophylactic antifungal. So this would be fluconazole, acyclovir, and levofloxacin if they're used. Antiemetics are commonly used. Here's your anti-nausea drugs. So this could be a serotonin antagonist, dopamine antagonist, MK1 antagonist. All these drugs are available to prevent some of the GI toxicity. If someone does have diarrhea, again, we always rule out infectious diarrhea before we treat that. Once it's ruled out, there's a lot of different antidiarrheals like loperamide that can be used. If they're constipated, again, we do the opposite. So that's where the stool softeners come into play, Colay, Senecot, Miralax. Again, because of the cardiac issues, again, we're going to be measuring their blood counts and electrolytes. And again, they should be getting routine ECG readings. And again, we're looking at that QT interval. The QT interval has to be corrected based on heart rate because we know slower heart rates have typically a longer QT interval. So there's a formula for that. And again, if the QT corrected interval is greater than 500 milliseconds, the epigenetic drug, as well as any other drug that prolongs the QT interval, should be withheld. And again, we consult with our pharmaceutical or our pharmacy colleagues, again, to help us identify what those are. Now, if we suspect differentiation syndrome caused by some of these drugs, the conversion of those cancer cells into normal cells, and then the pulmonary inflammation, corticosteroids are usually the first line of therapy. Again, this is going to be dexamethasone, quite potent corticosteroid, which basically blocks interleukin 1 and 6, so that the immune system can't talk to each other, and that's how you can block that inflammation. And then a lot of supportive care like diuretics, like supplemental oxygen. We can use that tretinoid drug again to help with that differentiation syndrome. And then fresh frozen plasma, coagulation factor replacements, just so they may not go into like DIC or things like that. And then for their pain or aches, fever, acetaminophen is usually the preferred drug because of the lack of platelet interactions. And again, keep acetaminophen less than 4 grams a day. And then tramadol for some of the pains that need a little bit stronger therapy. In terms of non-pharmacologics, as you asked, with the anti-nausea, drugs can be used, but again, we could put a cold cloth on their forehead. You can use distraction, guided imagery for hand washing, obviously wearing masks, avoiding sick individuals. For diarrhea, rat diet, bananas, rice, apples, toast helps soak up some of that fluid in the GI tract. With hypokalemia, again, citrus, bananas, things like that. If someone's having a fever, cold cloth, ice packs.
Fascinating. Thank you. Let's move on now to the administration. Are there any specific considerations that nurses should be aware of when administering any of these epigenetic drugs?
Many of them are antimetabolites. They're considered antimetabolites. These drugs insert themselves into the DNA, even though they're trying to block the methylation enzyme, but they certainly go into the DNA. So NIOSH, National Institute of Occupational Safety and Health, defines what a hazardous drug is. Are they carcinogenic, mutagenic, teratogenic, reproductive toxicity, meaning fertility, and organ toxics at low doses? So the antimetabolites, the DNA hypomethylators, and the HDAC inhibitors are on the NIOSH hazardous drug list and have to be treated as such. And we do consider them teratogenic. Now, the IDH inhibitors and the EZH2 inhibitors are not officially on the list, but again, they're suspected to be teratogenic, which is one of those categories. Decitabine is intravenous, and it can be given via a peripheral IV instead of a central line. And again, there's different protocols for that hypomethylating agent. Azacitidine is also IV, but it can also be sub-Q and oral. Verinostat and panobinostat are oral drugs. Romidepsin is IV, usually infused over 4 hours. Belinostat is IV over 30 minutes, and it uses a 0.2 micron inline filter. And then our IDH1 and 2 inhibitors and the EZH2 inhibitors are oral, either once a day or twice a day in some cases. Now, anytime you give an oral hazardous drug, which many of these are, those pills should not be crushed, chewed, broken. They should be swallowed whole. The patient or whoever's the caregiver should be using proper protective equipment with nitrile gloves, masks, things like that. The wrappers that the drugs are in are also considered hazardous, then should be treated as such in a specialty bin. In the hospital, we use yellow containers. And again, you have to take body fluid precautions 48 hours post that administration for urine, stool, saliva, etc. If you're giving the drug intravenously, if it's considered a hazardous drug, we have to use HD adapters like the Facile to limit spill potential and possible contamination to others, like through ingestion, which is swallowing, absorption, inhalation, and injection like a needle stick.
Great. Thank you. I really appreciate you calling out the hazardous drug potential for the certain agents and the associated PPE and protective equipment and environmental considerations that nurses should consider, as well as those they should teach to their patients if these are oral drugs that will be taken in the home. So I really appreciate that distinction. Moving on to that, what are some of the primary patient education points that we should be communicating to our patients or their caregivers about these epigenetic drugs?
It's really, really important to take these drugs exactly as they are prescribed. They have to follow the doctor's orders carefully, which requires taking them properly, doing the proper follow up. There's a lot of blood tests and appointments that we have to do to make sure that everything is okay. And again, because we know when there's non adherence, the disease progresses and becomes resistant. So that's really, really important teaching point. We have to monitor the patient for expected side effects and unexpected side effects. Again, anything that's concerning should be escalated to that healthcare provider. Teaching about the HD precautions for home with the meds, the wrappers, the body fluids, keeping the drug away from pets and children, because again, these are hazardous drugs. If the patient does become pregnant or wants to become pregnant, they need to let the healthcare provider be aware of that so that they can find an alternative therapy. Medication costs are through the roof. That's one of the drivers of why they're not adhering to the medication, and that affects their prognosis directly. So again, we have a responsibility to inquire about that. Let them ask these questions and feel safe to ask for help. We have resources, social workers, RN case managers to help find even the pharmaceuticals discounted drug programs or discount plans. Community organizations like the American Cancer Society, the Leukemia and Lymphoma Society, they do provide grants to help fund some of those fees.
I mean, I think you're so right in just pointing out that adherence is important, but there's different drivers of why patients may become non-adherent. And certainly it's not always, and most often not just an intentional choice to not take their medications. There are things that are influencing that outcome. And so I appreciate you calling out that we should be asking our patients and inquiring, and not just once at the beginning of treatment, but if these are long-term drugs that they're going to be on for months or even years, circumstances can change. And so once was something that they could afford or get access to without any problems. If their situation or circumstances change, it's something that we need to continue to ask to make sure that we're not overlooking or not opening that conversation for them to explain some of the challenges that they're experiencing. So I really appreciate you calling that out. You mentioned a couple of times, and I think it's certainly worthy of how we work with our pharmacy colleagues a lot, especially when we're working with these anti-cancer drugs. So how do you see pharmacists and oncology nurses collaborating to help manage adverse events, toxicities, provide patient education, and really just to serve as a trusted resource of information for our patients?
I work inpatient, and again, we have rounding. And so there's an opportunity for the nurses to interact with the physicians and the pharmacy all in real time for addressing the patient's issues. And again, the nurse typically is with the patient and understands what's going on, sometimes better than some of the other providers. So again, open and clear communication is the key. Treatment plans change, disease changes. There's a lot of things that change over time. And so our job is to do that constant medication reconciliation and make adjustments. Again, is the patient having side effects? Are there toxicities? Are there interactions with other agents? That pharmacist is able to, they have the database, the tools, the education, and the training to find those and help us find solutions to those. We have institutionally approved education platforms, Lexicon, Micromedics, Claims on Demand. So again, the nurse can look things up. And again, whenever in doubt, always ask a pharmacist. Usually they're pretty open to helping us because it's all about the patient care. We utilize telehealth all the time with communication tools, whether it's to a physician, whether it's to a pharmacist, through the medication administration record. There's links in there to message a pharmacist, or there's secure platforms, again, patient portals, et cetera, that can be utilized. And again, we always try to refer back to those reputable websites, professional organizations, patient community resources, your hospital or clinics resources, usually is what we promote.
So Eric, what does the future look like for these agents? Are there any new ones on the horizon? And how do you see their role evolving as far as their involvement in the landscape of cancer care?
There's always drugs in the FDA pipeline. Again, I'm not purview to a lot of those, but overseas in the European Union, they have little looser restrictions. And so there's a lot more drugs in their pipeline and approved drugs for that matter. Now, the future for oncology is going to be dynamic. Again, there's artificial intelligence, there's nanotechnology. The pharmaceuticals have these tools. And again, there's probably going to be more deregulation occurring with this current administration, which then is going to allow other drug companies to get into the game, so to speak, with biosimilars and generics. Again, once that period of exclusivity ends. So again, it just varies depending on what the product's for. Biologics, 12 years, orphan drugs, 7 years, new chemical entities, 5 years. And again, when more players are involved, increased supply, demand comes down, and access increases. Now, we expect the landscape to change dramatically over the next few years. And again, it's just an explosion of science information. As we learn more about the science, it's going to translate into practice. We're always identifying new biomarkers. These biomarkers are essentially DNA mutations or variations. There's so many variants of unknown significance. We know it's a mutated gene, but what does it mean? And again, once we find out what it means, can a pharmacologic drug be developed to block that? Liquid biopsies are on the rise. We're seeing that take over. And these are basically non-invasive measures that are measuring some of these biomarkers that are floating around in the patient's bloodstream, circulating tumor cells, circulating tumor DNA, extracellular vesicles, fragments of tumors. And again, the liquid tumor biopsies can be used for detection, for that diagnosis, for monitoring, whether there's a recurrence, whether there's progression, and they can even be used for prognostication.
Well, thank you so much, Eric, for sharing all of this great information today. Certainly, again, a complex topic, a complex class of drugs, but one that continues to grow and be impactful. So I really appreciate your time today and helping to explain some of those concepts for both me and our listeners. As we reach the end of our episode today, we like to always finish things off with a series of quick fire questions that will help summarize some of the things that we've talked about today. So to start that off, how do you think healthcare professionals should evaluate their hidden or their implicit bias when it comes to epigenetic drugs?
Every patient deserves biomarker testing. Very important, whether it's through IHC, polymerase chain reactions, or the most common next-gen sequencing. Again, there's several companies out there that have standard kits available. I wish we could test samples, whether it's bone marrow, blood, or tissue. And again, by allowing the biomarker testing to occur, even at the cost of that institution, it allows a better prognosis for that patient and even more treatment options possibly for that patient given their situation. And again, it comes down to finances. Oftentimes, that's the main constraint. And again, we have a responsibility to help find those resources for those patients when possible to help keep them on therapy.
What are some common misconceptions about epigenetic drugs?
Although there's limited efficacy as monotherapy, these are not substandard drugs. They're not inferior. They're actually used as part of the standard of care in combination. Now, the DNA hypomethylating agents, as azacitidine, decitabine, yes, they are first-line therapy. Others, though, your EZH2 inhibitors, your HDAC inhibitors, your IDH2 inhibitors are second or third-line therapy. Your IDH1 inhibitors are also considered first-line therapy. But this is indeed advanced targeted therapy. And we always consider it, is it as effective or less effective than traditional invasive chemotherapy followed by bone marrow transplant? And again, sometimes that is still the standard of care. But there's many times where the patient is older, they have a poor performance status, maybe they have several other comorbidities. And again, that high intensity chemotherapy or bone marrow transplant may actually harm the patient. Sepsis, neutropenic fevers, again, and they could die from the treatment, not from the disease. So given that, these drugs, epigenetic drugs, are typically sub-Q, oral, or IV very easily, and we could minimize their time in the hospital. So they're actually a better choice for some of these patients, which then allows to better control their disease and improving their quality of life, giving the patient back some control, again, trying to keep them out of the hospital to reduce healthcare costs. But it's still important that some of these epigenetic drugs, they still have the potential for severe adverse reactions. And they're still life-threatening, such as the prolonged QT interval, such as the differentiation syndrome.
What's something about this topic that's not often discussed, but you wish people knew more about?
This is precision medicine. This is what we've always dreamed about, tailoring the treatment to the specific patient. We've gone away from treating standard diseases like lung cancer and breast cancer the way they're supposed to be treated, to now looking at these biomarkers and using epigenetic drugs and other medications tailored to those variants that that patient is having, not necessarily based on their disease type. And it really comes down to that biomarker testing. Now, the Medicare and Medicaid are covering the cost of these drugs. They're FDA approved. They're scrutinized very intently. And again, there is great benefit to these patients, again, to take the medicine, to have their disease controlled for a long period of time, and to be at their own home, around their loved ones, eating their own food, sleeping in their own bed, etc.
What additional training or education do oncology nurses need to stay current on this topic?
We need to educate ourselves as nurses about these biomarkers. It's a changing landscape. And again, it's just constantly coming in. So you have to stay abreast of these changes, how they're tested, what the results mean, what's their significance. We got to learn about all these different drugs that are coming out. The whole point is to re-express a lot of these tumor suppressor genes that naturally protect the patient from cancer. Again, listening to this podcast is a great example of staying attuned to these changes. Join and become active in your professional organization like ONS or the local chapters. Again, there's constant continuing education opportunities, networking, developing these professional connections and resources to help support your nursing care. Again, ONS provides all the journals, ONF and CJON. Again, stay up to date on these new advances. The field of cancer is changing constantly, and so you have to stay current with that field. Things I did 20 years ago don't exist anymore. And also utilize our fellow physicians and pharmacists. They often will do in-services for us because, again, they have a greater sense of detail than some of the things that we focus on as nurses with patient care.
And finally, what are some additional resources for maybe patients or providers who want to learn more?
The National Cancer Institute, NIH, is considered the gold standard. Again, they have a big budget and they have a lot of resources for healthcare providers in the United States about epigenetics and epigenetic research. The National Institute of Environmental Health Sciences, also part of NIH, provides information about epigenetics. Of course, the National Human Genome Research Institute, again, can talk about the epigenome. There's Genetic Science Learning Center at the University of Utah. Again, there's interactive tutorials about epigenetics. EpigeneSys is bridges epigenetics and system biology. Epigene, again, latest epigenetic research and new products. The CDC.gov, University of Penn Epigenetics Institute is also a very good university that has a lot of information about this topic. And then there's some private sources. Promega Corp is a private institution that offers epigenetic overview at a price.
Outstanding. Well, Eric, thank you again for your time today and sharing all this great knowledge on, I think, a unique and less well understood drug class, but you've certainly helped us to learn more and be more comfortable talking about how these drugs work and what they're used for. So I really appreciate your time today. Do you have any final comments to share with our listeners?
So we thought CAR T would be the magic bullet, and it wasn't. And likewise, again, some of these epigenetic drugs, are they the magic bullet? Unfortunately, they're not. Unfortunately, the diseases continue to change, the diseases continue to progress, and they get worse over time. We still do not have the full picture, the full understanding of the complexities of this process. Certainly, we've seen progress in helping patients living longer and in better quality of lives. But again, we still got a lot more to do. As a nurse, if you understand this epigenetic concept that these mutations can occur and then we get cancer, or cancer cells can hide the tumor suppressor gene expression to help promote its own survival, again, through DNA methylation, trying to hypomethylate, loosen the DNA, express the tumor suppressor genes, through histone acetylation, again, by increasing acetylation of the histones, which then loosens the DNA around that chromatin, around the spool, again, re-expressing the tumor suppressor gene, by blocking the mutant IDH1 or 2 enzymes, by blocking 2-HG, that oncometabolite, through histone hypomethylation, by blocking EZH2 inhibitors. By understanding that, again, re-expressing tumor suppressor genes to help that patient, we're basically prolonging their life, improving their quality of life, slowing down the progression of the disease, having long-term control for a period of time, as long as adherence takes place. And again, we can educate. As a nurse, you have to be able to translate that medical jargon so that the patients or caregivers understand the significance of what they're taking. Again, they're the ones taking the drug and living their lives. And so again, we could partner with them better to help them achieve those good outcomes. Lastly, I want to just thank you, Jaime and Waleed and ONS for offering this opportunity for me to share my insight on this matter. And for our audience, I'm on 3 posters at this upcoming ONS Congress in Colorado in April: testicular cancer awareness, easing the COVID restrictions on bone marrow transplant population in the inpatient setting, and related to this topic, carcinogens and cancer genesis for public education. So please check those out if you have that time. Thank you.
Wonderful. Thank you so much, Eric. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.